All right, we're now going to do cardiogenic shock. This is admittedly both an important risk factor that's not super common because it's fairly strict definition, but it's also not exceedingly rare, and it is actually a powerful risk factor. And you know, in trying to clarify this one, we just read the definition, tried to figure out what the intent was, and you know, the intent here was that you know, it had not just any degree of shock counted. It had to be, you know, shock sort of at the time of the procedure, although one of the big improvements they did was they gave you, you know, 3 choices, which is yes, within an hour of the procedure, essentially, which they call at the time of the procedure. Yes, not at the time of the procedure, but within the previous 24 hours. And that's nice because I think that 24-hour one allows you to capture some risk for shock that has actually been treated successfully but was really truly present there. The tricky part is, you know, when they read it, it says, indicate the patient has developed cardiogenic shock. Shock is defined as a sustained greater than 30-minute, we'll come back to that, episode of hypoperfusion evidenced by these numbers, which would not have exactly been the cutoff I chose, but at least they don't give you a range, which is less than 90 for the blood pressure, 2.2 for the output, and or a requirement of support to basically maintain things above this level. Therein lies the rub, because you get the patient who, you know, was in cardiogenic shock, gets put on, you know, norepinephrine, epinephrine, and balloon pump, whatever you have, and their blood pressure is 105, and you go, okay, that's for, and you know, 5 days later, and they go to the operating room. Well, that patient was, you know, there's a lot of drips, there's a lot of support, they're still in shock. And then you have the patient who's, you know, they were in shock acutely, they maybe got a little bit of dopamine, they got heparin, et cetera, they got CAS, et cetera, and then, you know, we don't like to take people to the operating room when they're in shock, right? We like to get them out of shock before we take them to the operating room, so that's usually what we do. But then they go to the operating room, they're sitting up, they're walking around, they're on dopamine 1 just because we haven't gotten rid of it, or, you know, dopamine 2, their blood pressure is 130, that patient's not in shock, right? So wherein is the dividing line between those two things? That's what this whole convoluted thing, again, blame Dr. Matheson for this one because he gets to follow up on it. But I sort of sat down and tried to figure out, you know, various degrees of support and so forth. And then the other thing is, what was I going to say? And I now, I forget what I was going to say. But so the sustained thing. I know what I was going to say. Balloon pumps, that's one of the things. The balloon pump can be put in for angina. And a balloon pump, I'll make the point that what does balloon pumps do to your systolic blood pressure? Makes it go down. That's what that little diagram of the balloon pump that I put in the thing is about. Just pointing out, because I'll see somebody who did not meet the blood pressure criteria for shock, but then we put in the balloon pump and people start reporting their systolic blood pressure as being, you know, less than 90, and I'll read the chart, and it was put in for angina, and somebody wants to say they have shock because they believe balloon pumps are put in for shock, which they can be, but that's not the only reason, and they'll believe that the systolic blood pressure is less than 90, not understanding necessarily or not processing that the augmented systolic blood pressure is actually by design, the balloon pump's meant to lower it. So anyway, that's what that diagram is about. What else is there to say? Oh, every once in a while I'll see somebody in the lab who, you know, is presenting pretty acutely. They have like a high-grade left main. They go to the operating room like the same day. But in the cath lab, they got a little nitroglycerin or something, and their blood pressure dips, but then it comes right back up, and they don't end up on support. Those patients don't necessarily have shock. That's what the 30-minute thing is. On the flip side, and I'll say I see this as well, do I wait 30 minutes to treat somebody whose blood pressure is 70? Not a chance. So, you know, if I put somebody on high-dose inotropes, if they don't have blood pressure less than 70 or less than 90 for 30 minutes, because I got them on high-dose drips sooner than that, and their blood pressure comes up to 95 on, you know, norepi and so forth, that patient does have shock, and even though they don't technically meet the STF less than greater than 30 minutes, that's where the judgment comes in. So when I read these things, and I see they got a little nitroglycerin, et cetera, I look at what their blood pressure did and how much support they have going into the surgery and so forth, and I did that for a while, and then finally I said, well, you know what, you got to make these judgment calls. Let's write it down, and let me make it as simple as I possibly can. And this was how successful I was at making it simple. Let's see if this, so I came up with, let's see where it is. Oh, I guess we don't have the long version. Where's the long version of my clarification? Nope. Okay, so I came up with, do we have my long clarification in the slide? We don't. It's in the training manual. Okay. I'm sorry. So in the training manual, you're going to see the long version of this, and I apologize if I would put it in the slides. And what you'll see is what I've listed is essentially, and we're open to advice on, you know, if there's some places that this doesn't work, and you know, but basically what I tried to figure out was there are some patients for whom their blood pressure and cardiac output are so good that I don't care how much support they're on. I suspect that if you took it away, they'd still be above the cutoff. So there's, you know, so if they have a sort of a frankly high cardiac output, high blood pressure, and I don't care what level of support is, what you should have done, frankly, clinically, is back down on the support and see what happens. Because how many of you were nurses, you know, like ICU nurses and so forth? How often have you seen us back down on drips that we thought the patient needed? And when you take everything off, their blood pressure, you know, and the hemodynamic things improve. So when you have, you know, sometimes they're not, the hemodynamic meds aren't doing anything. So that's what, there's one category where I said, look, these numbers are so high, I can't say that they're in shock no matter what they're on, short of maybe, you know, an LVAD or ECMO or something like that, which will qualify separately. And then I picked a sort of a middle zone where I sort of said that their numbers are, their blood pressure is high enough that I think they need to be on high levels of support in order to say that they really needed the support to maintain the numbers. And then I picked another category where I said, well, these numbers are almost meeting the shock criteria, and so really any level of support, you know, like if the blood pressure is 95, they don't need to be on very much support to say if they were off the support, they would have a blood pressure less than 90. Does that make sense? So those are the categories I came up with, and then I sort of made cutoffs for high levels of support, low levels of support, and that's how I tried to do it, and that's what that whole convoluted thing is about. The STS correctly makes the point, if somebody presents with, quote, without symptoms and they meet these numbers, you know, who would that be? If somebody gets electively admitted for a cath and for some reason their cardiac index is 2.1, maybe they get, you know, maybe they find they have an ischemic cardiomyopathy, they get admitted to the hospital and they don't get put on support, but, you know, that's not shock. That's just either a mismeasured cardiac output or, you know, shock should be somebody who's actually presenting with an acute syndrome, who's, you know, acutely ill. That's basically the point of you need to have symptoms. And the vast majority of times you'll be stewing over this diagnosis that they'll be presenting acutely, and it'll be difficult, but this is the best I could do, and this is as simple as I could make it, I'm afraid. And I don't know whether there are any questions. And I will say very, 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 very often what we want to do is get the person out of shock before we send them to surgery. So typically, if we've waited a while, you know, if we've waited 5 days from the cath and when they presented to take them to surgery, quite often they're no longer in shock. That was the whole point. If the patient who was going downhill or who was so acutely ill initially that we didn't think we could wait, those are the patients who might be in shock when we take them. So you want to, but you know, I do see cases where really and the ones that I tend to disagree sometimes, whether somebody wants to say shock, and I'll look, and the surgery was done 5 days later. They were sort of on some level of support, but they really had very clearly stabilized, and then that's when I get at the cutoff to try to figure out, did they need the support or not? Does that make sense? And then we make comments about, degree of impella and so forth. So impella comes in 3 different sizes. The biggest size can almost support a heart that's acontractile, but the smaller size is nowhere near as much support, so that's a little bit of a gray zone. We do make the comment that if you get put on ECMO in the cath lab, we both count that as resuscitation, and we count that as shock. So, because that's, you're basically getting put on cardiopulmonary bypass, and occasionally people wait a couple days before they go to the surgery with ECMO. Was there any questions? All right, yes.
Can you elaborate on how SCS says LVAD alone is not sufficient to document shock without blood pressures?
Without blood pressures. Okay, so they say that, and I'm trying to think of a scenario where I put in an LVAD. Oh, I know what they're saying. They're saying pre-existing LVAD. They're saying a pre-existing LVAD, I believe. Okay, I remember reading this. If you put an LVAD in acutely, which we frankly rarely do, that scenario is I can almost not think of that. What will happen is they'll go to bypass surgery and get the LVAD as really a consequence of the surgery. So what we're talking about there is a very rare circumstance, but not completely unheard of, that an LVAD patient comes in for a bypass surgery, and what they're saying is that LVAD patients are not considered to be in cardiogenic shock just because they have a chronic LVAD in, okay? Now, what is the problem with saying anything about the blood pressure in an LVAD patient? What is the blood pressure of an LVAD patient? LVAD being a continuous flow system. You can't use blood pressure, so but I'm just going to say this is pretty darn rare that we have somebody come in with an LVAD in place and then do a bypass surgery on them. I can't actually think. Have you seen that? No, I mean, I can't. That scenario, but that's, I believe, what the qualification means. What they're saying is, what if you do a bypass patient in an LVAD patient whose the LVAD pre-existed, has been in for a year, 2 years, does that mean the patient has shock? And they're saying, maybe, maybe not, and I'm going to say that scenario is really, really rare. Okay. Okay, I think I'm going to, whoops, what did I do?
Another question.
Another question, okay. You know what, I almost made it off this slide. And go ahead.
Well, there's this one that I think I can even answer. Do extractors need to send in documentation to support cardiogenic shock if within 24 hours or just when present at time of procedure? Yes, they need to send in documentation within 24 hours. But then there's another question, what about impella support?
So, so let me look at, so I mentioned that I consider impella did I make a distinction on the size of the impella?
No, I don't know.
Okay. That's actually an improvement I can make, and I'm not sure why. I think I was, in my effort to not make it complicated, I considered an impella, I believe, a medium level of support, essentially. However, I either considered it high level, now I considered it a...
You said 5.0 was resuscitation, but 2.5 and before are just...
Moderate shock, okay. So I think what I said was an impella was a high level of support, unless it was a 5, in which case I said it was like the equivalent of ECMO, essentially. So that was, yeah. So I guess we should probably spell that out a little more clearly. So impella I did list impella, and it's considered we considered it a high level of support, whereas the balloon pump we considered, I think, a medium level, a lower level of support, just because balloon pump is much less support than an impella. And the largest impella, again, is almost the same as ECMO, not quite, but it can be used as almost like a bridge, sort of a short-term complete cardiac support. In other words, the heart barely has to be contracting with the largest impella. So it comes in 3 sizes. It's kind of the Goldilocks thing, but it's a 2.5, a 3 point something, and a 5. Okay. Does that answer that question? No, another question, yes.
I think so, but I've got another one.
Okay.
So this one is a maze question. Did
A
I
maze
understand-
question?
Yes.
Oh, it's too late for mazes. We got off maze. I escaped the maze. No, go ahead.
Now, when they come to me, I just
No, go ahead. I'm just...
Did I understand Dr. Steinley to say that a full open maze requires opening of just the left atrium and making cuts or burns to the interior? Does that mean that the right-sided maze as well as left is not required to exclude the case from isolated except for mitral valve?
In other words, if they do a maze only on the left side, is that not a full open? Is that, okay. Yeah, if the question is, do they need to do the right and the left side? In other words, if they just do a left atrial maze and not a right atrial maze, but they meet the criteria of opening up the left atrium, et cetera, is that still a maze? As our surgeons, this is the definition that came from our surgeons, and I think the answer to that question is yes. If they do nothing to the right atrium, they are not doing the type of maze that many people would recommend, but we would say that was a full open maze. Now, let's think about this. This is part of the reason we've excluded the mitral valve surgery. So for a mitral valve surgery, you're in the left atrium anyway, so if you just do some stuff on the inside of the left atrium, and not anything to the right atrium, you probably weren't really serious about this maze, but in any event, we're not going to exclude the surgery because it's a mitral surgery. But if you're doing an aortic valve replacement or a bypass, and you go to the trouble to open up the left atrium, do some stuff on the inside, and you don't do anything in the right atrium, that's actually unusual, but the risk of the surgery is still probably elevated, and it would be excluded. And another question.
The webinar people are having trouble hearing you.
I'm too far away from the mic. So I'm going to sit here and not pace. So basically, I did say that if you just do work on the left atrium, then that would be a full open maze if you do the inside of the left atrium. Except for the mitral surgeries, that's not excluded anyway. And to be doing an aortic valve replacement or a bypass surgery, and to open up the left atrium, take the trouble to make burns on the inside, and not do the lower risk work on the right side would be, possible, but not the common way that people do this procedure. Nonetheless, I think the risk is mainly probably associated with opening up the left atrium. And that's how our surgeons defined it on the panel, because this is their definition. Any other questions? And you can see why I wanted to just count all mazes, because I was wanting to save Dr. Matheson from never exiting the maze. All right. And this is my brilliant point about balloon pumps. I use this with the residents. Okay, resuscitation. And resuscitation indicates whether the patient has required cardiopulmonary resuscitation, by which we mean chest compressions, actually. They need to be pulseless or to require chest compressions. And then the nice thing that they've done is they've added that time window for this one as well. And there's within an hour thing. And then this is one where the time matters. So you're my keeper of the clock. Do you know what the time on this one is? It says induction of anesthesia. No, I'm sorry. This is the one that's incision, but yes, okay. This one's incision, but they then correctly say if the patient codes after induction of anesthesia, that doesn't count. So there is a time window within the hour or 24 hours, whatever you're talking about, where it counts to the time. But if the resuscitation occurs in that time window, it doesn't count as resuscitation. So you time all the timing calculations from the incision. However, if induction of anesthesia, which may occur before the incision, if the resuscitation happens after that, you're going to attribute it to the induction of anesthesia and not count it. So this is one where they mention induction of anesthesia, but the time is from incision, which is a little bit confusing, but not any more confusing than what we just did. And ECMO counts as resuscitation, as does, we decided, a 5.0 Impella. And cardiac arrhythmia, and So we're going to get into the various cardiac arrhythmias, but there's a parent variable, which is just yes or no, and then you get into the, so SCS says it needs to be treated. I'm just going to tell you, if you want to do that, fine, but we would accept it based on the definition of the arrhythmia, not whether it requires treatment. And then is this a clarification? If the definition of treated for arrhythmia means they were treated for arrhythmia, isn't that what that says? That's not much of a clarification, but anyway, so VTach, VFib, I think that the things to point out are, so there's a 30-day, there's more than 30 days, less than 30 days, and then VTach needs to be sustained or persistent, et cetera, requires. So what does this mean? So I'm going to make an exception for this. Sustained means 30 seconds for arrhythmias in general. So that's what that means. This is where I make it. This is this sort of. It's not exactly the same as saying a treatment's required. If perchance they shock them in less than 30 seconds, you can count it. Now, how hard is it to shock somebody in less than 30 seconds? Pretty hard. Those nurses deserve a gold star and credit for this variable just because they're so fast. The only place I've seen that happen is in the cath lab, maybe, where the pads are already on. I mean, it almost takes 30 seconds to charge the thing. Unless you're in an EP study and you're deliberately fibrillating a patient, to do it in 30 seconds is pretty hard. But so either it lasts for 30 seconds or they shock them out of it within 30 seconds. Because other than that, then it's non-sustained VT, which is not supposed to be captured by this. Or, for that matter, little runs of torsades that self-terminate. Not supposed to be captured by this. Does that make sense? And then we haven't been asked about this in a long time, but they point out that just because you had sustained VT in the past and have an ICD in place doesn't mean you've had this in the last 30 days. Now, I don't remember the answer to this, but I think we've been asked, oh gosh, I hope somebody helps me with this. What if the ICD has fired in the last 30 days? We were definitely asked that. And I think what we said was if you knew I mean, you can have an inappropriate shock, so obviously you're not going to code an inappropriate shock for AFib in the last 30 days as VT, but I think if you knew it was for VT, I think we said you could code it. Anybody remember the answer to that? Anyways, is it in there? If I say, oh, look at that, we already answered that question. I said the same thing. All right. 95% of the time I answer questions the same way, but 5% of the times I disagree with myself. So those are really tough arguments. So, all right. A flutter is, they gave you this lovely description of what flutter is that you don't need to know. Somebody just needs to say they have flutter, and then, all right, and then they say when it occurred, and then they're going to talk about, okay, I'm trying to think if there's anything that's complicated here. This is the description of AFib, less than or more than 30 days. Okay, so this, do we really capture this? Because does this have any basis, because I think we were capturing this because it had something to do with whether it was a post-op complication, right. But it doesn't anymore, I don't think. So, but anyway, so the one that I disagree with is to say it's persistent. Oh, okay. Yes, actually, I don't disagree with this, actually. I take it back. What they're saying is they're going to define persistent as more than 7 days. Clinically, actually, we sort of say, but what they're going to say is if you cardioverted them out of it in less than 7 days, but you had to cardiovert them out of it, it's still persistent. So basically, the concept here is paroxysmal AFib means you go in and out of it on your own without needing us to help you. And you give the person 7 days to get out of it on your own before you declare that it isn't paroxysmal, unless you were impatient and cardioverted them out of it sooner. So, but if they've been in it for more than 7 days, that means they're not going in and out of it on their own and they have persistent. It really doesn't matter very much, but go ahead. Question?
Treated for arrhythmia, what would that be for second-degree heart block or third-degree heart block? Let's say the patient is stable, does not require pacing, would no beta blocker be considered treatment?
So I'm not going to require, if they have the second-degree heart block one that we, no, but the third-degree heart block is, so if they have third-degree heart block, I don't care how they treat it, you can just document it. Now, the one exception to that is the STS explicitly says a pacemaker means you cured the condition. So if they have a chronic pacemaker that was put in, before they came in, and you know that it was for a third-degree heart block, they don't want you to code third-degree heart block. That's a clarification they've made, and unless they've reversed that, so I don't recall if they have. But if they present with third-degree heart block and it's stable so that you don't put a temporary wire in and you don't put a permanent pacemaker and you take it to bypass surgery and put the pacemaker in with the bypass surgery, which I guess is probably what you would do, that's still third-degree heart block. The treatment shouldn't matter. Okay. And then, anyway, this is less important, but yeah, basically paroxysmal means you go in and out of it on your own, and the 7-day thing comes in, well, how long do you have to wait to decide they're going to go in and out of it on their own or not? And the answer is 7 days. After 7 days, you say, you know what, it's persistent. But what if you shock them out of it before then, it's still persistent? Yes?
Just a concern about interface with STS on this one.
Yes, please.
The patient has paroxysmal atrial fib
Yes.
Before or during arrival.
Yes.
But prior to or goes into normal sinus rhythm, is treated, let's say, for the AFib.
Yes.
And for STS, there's a complication of AFib. If post-op, they go back into AFib.
Yes.
We don't address that or look at that per se here. I'm wondering if we shouldn't.
Do we not have AFib as a...
No, post-op?
Yes, we do.
I'm sorry. So, but I'm talking about the person that goes normal sinus rhythm, right, pre-op.
I think it's non-existing pre-op, but post-op complications.
And we're not presenting the slide set post-op AFib?
I'm sorry.
At the end.
Liz, your question is, what about paroxysmal and post-op?
Yeah, no, I'm asking about the pre-op.
Okay.
Pre-op we mark paroxysmal AFib, but there's no way to show that this person is really a normal sinus right pre-op, immediately pre-op.
Right, so you need to know that so what you're saying is this variable does not help you code the post-op AFib. I couldn't agree with you more, which is why this variable has now become unimportant, because it does not help you code the post-op AFib, because somewhat inexplicably, in my opinion, they have said that if at any time prior to what they have said is this may be somebody who goes into AFib every day, right? Or they're in and out of AFib frequently, and they're still going to say if on the minute you go into the operating room you're in sinus rhythm, then we're going to say it's the surgery that caused the AFib afterwards, even though that's a ridiculous thing to say in somebody who has a history of PAF before the surgery. Right? But that's what they say, correct? So they want, so as an abstractor, and I guess we're not doing post-op AFib, that's what I was looking for, is you need to know both do they have a history of paroxysmal AFib, and at the moment they went into the OR, what was their rhythm?
Which is not coded.
Which is not separately coded. You're going to have to look at the chart separately to make sure you know what their rhythm is. Fortunately, in EPIC, it's actually easy to do, and often, in fact, the anesthesia note is going to tell you what the rhythm was when they show up, and then that'll, help you. And if it's permanent AFib, that does help you, but for the paroxysmal, it doesn't. And I
just would ask that maybe that be included or considered to be.
What would be? Oh, the rhythm at the time of the OR.
Rhythm at time of OR.
Well, so there are lots of things so your point being, should we include that?
Exactly.
To sort of facilitate, is it helpful to you? Because you're right, you need to know the rhythm. There are plenty of things you need to code the full STS data set that we don't ask for. And what you're saying, though, is it might be helpful if we did ask for it? Okay, we can take that under advisement. I think, though, that I think you should just have a data collection sheet where you say what was the rhythm when they went into the OR, because you need to know that, and not necessarily give it to us. Because Because there are lots of other things, like the STS asks you for how many variables? You don't want us to ask you. You don't want us to ask you for all of those. That is the point I was making. Yes.
Post-op AFib as a
We do. That's what we did. Yeah.
But you excluded if the patient was in AFib at the start of surgery.
Correct.
Yes. So, but it is on there as a post-op.
Yes.
complication.
It is there as post-op complication, and there's plenty of other things. Like, so for instance, we don't ask you to write, I don't think we ask you to write, to report incision time or induction of anesthesia time or discharge, or you ask the discharge date. But there are lots of things you need to know that we don't ask you to formally report.
Right.
So you're going to be writing them down somewhere, right? Because if I was doing this abstraction process, I'd be writing down, okay, what was incision time, when was the MI diagnosed, and we don't ask you for those dates and times, but you need to know, you need to write down the time and the date. Otherwise, you can't calculate these things. Yeah.
Okay, so I want to make sure I'm understanding what you're saying. So the patient has paroxysmal AFib.
Correct.
They go into the surgery and sinus,
Correct.
and then they have AFib afterwards.
Correct.
Is that a complication, or did you
It's a
say they already had?
No. So what would I say? I would say that's not a complication. What is the answer? The answer is that is a complication.
Okay, that's what I want to
Yeah.
understand.
So that's one that I think everybody was like, really?
Yeah.
Like one of the things that makes you sort of incredulous. But you know what? My ability to be credulous index has gone way up in recent months, I have to say, because I see lots of things in the newspaper which I'm like, really? All right, third-degree heart block, I think we talked about. Cardiac arrhythmia, blah, 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 the definition of AFib, we talked about this, and that's why I was saying is, because previously, in a previous iteration, knowing they had paroxysmal was useful. It allowed you to say, oh, they can't have it as a post-op complication, but then they changed the definition, so this variable is no longer that useful, doesn't help you at all, except maybe if it's persistent, because then maybe you just assume they're in AFib the whole time without checking, but I don't know. Okay, warfarin use, that gets back to the INR thing that we want to know, did that affect the INR? It happens to be here in the AFib section, so it's a little out of order. Okay, coronary anatomy. This is where it's whether it's known or not. Document sometimes results of known and verbally communicated surgeon, blah, 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 blah. Okay. All right. So this is one where if you talk to somebody, this is one where if you know about this and soon enough, you can hopefully go track down what the anatomy was, because it would be to your benefit not to be coding, well, this is basically the same as saying, I jumped in so quickly that I coded the chart before the chart was completed because they hadn't had a chance, or maybe they never get around to dictating the CAF report or something. But if somebody capped this patient, right? Somebody wants to bill for that procedure. To bill for that procedure, they need to dictate it. Maybe the dictation happened later and didn't end up on the chart, but this should almost never happen, in other words. This particular scenario that they talk about where the patient was capped, the results were known, and for some reason it just wasn't known at the time of abstraction. So you should be able to track it down in most cases, but I guess that's what that means. And then this gets us into the number of coronary vessels, which is a little tiny bit complicated, but it's kind of just being sort of and this was just us trying to interpret what they said and then adding the bit about what do you do about left main and what do you do about left dominant circulation. So it says indicate the number of diseased vessels, and they're sort of considered to be three systems, LAD, circumflex, and the right. Now, one thing is the number of bypass grafts is not the number of diseased vessels. Not the same at all. Also, clinically, is 50% significant? Do we bypass 50% vessels? Maybe, maybe not. Turns out clinically perhaps we should, but we sometimes, consider a 50% vessel as, quote, not narrowed, and we will not bypass it. But for the purposes of STS, if it's greater than or equal to 50%, it's diseased. One question we've been asked is, what if they said it was 40% and then the FFR was, quote, positive? Should you count that as diseased? What do people do? I'm seeing people nodding their heads. Do you count it as diseased if it's 40% and the FFR is positive? So the answer is you can. The way we've answered this question is we say you can. And that leads us to the question of, what is a positive FFR? Everybody know what do people use as positive FFR? What cutoff? Do they just look for the word positive or significant or something? So the cutoff, I, as a non-interventional cardiologist, disagree with this, but the cutoff that is accepted is 0.8. So what that means is the pressure drops off by 20% on either side of the lesion on this flow, or the flow does on this flow thing. There's a newer device, actually, what's the OC, what is it, OC? The newer device is called, uses a different method?
Well, there's the IFR, which is instantaneous.
Instantaneous, okay. Yeah, and that actually measures more flow instead of pressure, right? Okay. And then there's also adenosine or not adenosine. So you're basically going to look and say, did they think the FFR meant it was a significant lesion? The cutoff is 0.8, and they sometimes have to give adenosine to provoke that 0.8. Then you can count it as a diseased vessel, because that's actually a test we consider more reliable than angiographically looking at the severity of the narrowing. And do we think a positive FFR is 70%. So is it likely to be greater than 50%? Yes. Does that make sense? There's one slight nuance there, which is sometimes the FFR is the result of the sequential lesions, the cumulative effect of them. But anyway, a positive FFR, even if it was read as angiographically less severe, you can count that vessel. Okay. And then the last bit is, valve misadventures. Sometimes what happens is during a valve surgery, the aortic valve occludes the ostium of a coronary artery, or, and I love these because it happened to one of my patients, they throw, and it's really, I'm amazed they don't do this more often. When they're sewing in a mitral valve, they throw a suture around the circumflex. And if you think about perivalve leaks, the difference between avoiding a perivalvular leak and going through the coronary is like a half a millimeter. This is why I'm very impressed by surgeons. They're really making a tough call. They want to grab enough tissue that they don't get a leak. This tissue is often calcified, and they don't want to throw a suture through the circumflex, which is right there. So anyway, when they didn't have they have a negative cath and they have to do a bypass surgery after the valve, that's not a reportable case, okay? Because if they bypassed the LAD because it was diseased, and then post-op they have to throw in a graft, that graft is a complication of the first surgery, so it's not counted as a separate surgery, and the number of diseased vessels would be 1 for the LAD. It wouldn't include the graft that they had to put in as a consequence of the valve. Does that make sense? A more common scenario is they didn't do a bypass at the first surgery, in which case this is not a reportable case because there's no bypass. They threw a graft in as a complication of an isolated valve. Okay.
But sometimes it's coded as a CABG ×1, and that's reported, that's billed for, and then we'll get the discrepancy report. Right. So we still stick with no, it wasn't CABG?
Correct. We see this all the time. Okay. We fully understand this, that this is exactly right. They're going to bill for the bypass. Yeah. It'll have been a separate trip to the OR, or perhaps actually they'll recognize it in the OR, but the patient had no coronary disease. And, well, you know what? That's a good question. I'm usually thinking in a scenario where it was a separate case where they went back, but I would count, there's no reason to count those separately. If the patient had no coronary disease and the intent going into the OR was not to do a bypass, and they happen to have a complication that requires them to throw in a graft in the absence of coronary disease, that should be an isolated valve that's not counted. Yes?
Okay. In the past, valve misadventures were not to be reported, but then we were told all CABs had to be reported, even valve misadventures.
So we want to know about the case, but it won't be part of your risk-adjusted number, because we want to know about all your open heart cases in order to, because basically we want to have the opportunity to decide is the case count or not. So we want to know about the case. We're just not going to put it as part of the scenario we just talked about is I'm going to do an isolated aortic valve replacement in a patient who has no coronary disease, the bicuspid valve with aortic regurgitation. They're 20 years old, coronary clean as a whistle. I block off the left main with my valve and have to do a bypass. That is an isolated valve. It'll say CABG on the discharge summary, but we're not going to report that because that's not the type of surgery. That's the same as if it was recognized afterwards in a separate surgery. Does that make sense?
But we should submit it to you, but you won't count it.
Well, you should explain, hey, we think this is one that we don't think counts because to make sure we don't miss the scenario, but yes, that's one that should not count.
Can I ask another one?
No, you're done. No.
So in a scenario where you have a valve.
That might have got left on the slide, I believe it's not in the training manual.
Okay.
You're telling me you have a valve
Okay.
procedure planned and they have complications.
Yes.
And the doctor does a quadruple bypass.
Yes.
And the patient dies, so there's a mortality, and what's the reporting mechanism now for this?
Generally speaking, things that occur as complications of the initial surgery are not counted as a surgery. And so I would say that the more common scenario that I see is they actually leave the OR and come back. But basically, if they went in and
Caths were cleared.
and there are negative cath,
Right.
and what they say is they damaged the coronary or they obstructed a coronary in the process of doing an isolated valve surgery, and they had to throw a bypass graft in, and this does happen. That's still, in the same way that I don't count a pericardial stripping if it wasn't the intent of the surgery, I'm not going to take an isolated valve and make it a reportable case just because they had to treat a complication of the surgery with the bypass graft. Does that make sense? And is that
I
something?
just changed it, so.
Okay.
It's not in the training manual, but that slide had. said
Command B. Well, we want to know about them because the thing is, some of these are going to be. We want to be able to sort of analyze and make sure that this is what we think it is. Does that make sense? We want to know about all your cases because that's how we. Otherwise, we can't. The reason we want to know about it is we're going to get that discrepancy report, and we're going to say, why is there a discrepancy? If we know about the case, then we know why there's a discrepancy.
Helps us to those.
Yes. Yes.
So we had a specific case that I got the DQR that they did a root replacement. They took off the coronary, replaced the root,
Yes.
then used graft
Yes.
and helped them reimplant the coronary.
So that's not.
On the coding summary, it does say bypass graft, but it wasn't. They weren't local bypass.
And correct. So this is not a reportable case because that type of root replacement is excluded from our public report anyway.
Yeah.
So this is when I get asked these questions all the time. A case that we don't care about, and then people say, well, you consider this a bypass surgery or not? And to some extent, I'm a little agnostic because I don't need to know about this case ever because we're not going to ever risk adjust that particular procedure, which has an acronym. I forget the name of when they extend the coronaries. My aortic surgeon I asked him about one of these cases. Anyway, when you have to extend and reimplant the coronaries, is that the same thing as bypassing the coronaries? No, it's not the same thing. I would count that as not a bypass. It may or may not get billed as a bypass. What you're really doing is reconstructing the coronary, which we sometimes do for congenital disease. We unroof, et cetera. We don't count that as a bypass either. Sometimes congenital coronaries are bypassed. But anyway, the bottom line is that procedure is not going to be in any of our reports, so I kind of don't care, but I would count it as a bypass. Does that make sense?
No, I don't think it counts as bypass.
Yeah. Does that answer your question?
So my question then would be, knowing that it's not a bypass surgery,
Yes.
do I still then report it to you, so then you can say that it's not? Or
Got it.
can I-
Is it listed in the billing as a bypass?
It is.
I think, what would you say,
I
Holly?
would say go ahead and submit it, email the CCORP mailbox,
Yeah.
and then we'll.
So the purpose of this is we're going to say, gee, you billed for this many bypasses and you reported this many. It's useful for us to know why the discrepancy.
It
Yes.
just keeps us from then you calling us when you get your discrepancy
Right.
report and saying, this,
And so we're not going to publicly
and it
report
gives
it.
us a really better accurate count of that.
Yes. And questions?
To the mic.
Yes, I'm sorry. I'm going to you know what? Can you hear me now? Okay, I'm going to.
A leash?
So I've got two questions for you. One, so we don't enter the case, but just call to let you know. If we enroll the case, how will you know if the CAB is only due to valve complication?
Could you?
Answer that.
Okay. And
That they should enter the case and upload the op report, and we will let them know if they need to code it and all other non-inclusive.
Sounds good. I'm now wearing a portable mic, so if the folks out in webinar land can tell me if I'm not audible, because I cannot be trusted to not pace, evidently. Okay. And then the last bit about, was there a question? Yes.
Can Dr. Steinley clarify if we should be reporting aortic dissections which require an RCA bypass graft?
Well, I'm going to ask Holly, but I think the answer to that is yes. So a bypass, it's not going to be reported. It's going to be excluded due to aortic dissection. Do you want to have them report all bypass surgeries where there would be listed as a cabbage, even if there's an obvious exclusion? Even if there's an obvious
Yes.
Yes. So I think the answer is yes.
And it goes back to this statute where it says report all, and the regulations where it says all cabbages will be reported to OSHPD. And it just got to where hospitals were making this determination on their own, and it started to morph into cases that shouldn't have been excluded, so we decided the better way is report them all. If you think it should be or know it should be an exclusion, you upload those documents. We'll see that documents were uploaded. We'll reach out to our cardiologist just to confirm, and we'll let you know, and then we'll take it out of the data.
Yeah, so the case you mentioned will for sure be excluded, but we'd like you to report anything where it's listed as being in cabbage so that we can explain to ourselves the discrepancy report, and we won't hound you about it. Also, it turns out people have said, oh, I think this case is excluded. We then see it. We see it in the discrepancy report. We say, why was that excluded? Then they explain why it was excluded, and we say, actually, that shouldn't have been excluded. Hence, to save that, to save Dr. Matchison from having to answer that question, which is what happens, just upload the data and let us know that the case occurred and why you're excluding it, and it'll happen up front. All right, and then this gets us into the kind of complicated bit about, we talked about the severity of the disease, and then basically left main counts as your LAD and your circumflex. Left dominant circulation, you sort of talk about the inferior wall and the lateral wall as being two distributions, so a proximal left dominant circumflex counts as two vessels, and then the first order side branches count as that system as well, and then the last bit is the ramus, which is kind of in between the circumflex and the LAD. We figured out what do we do with that, and we basically said it's like the wild card in any kind of card game. You can count it as whatever you want. You can count it as an LAD or a circumflex, depending on which one will get you. Like if the circ is diseased, you might count it as an LAD. If the LAD was diseased, you might count it as a circumflex. And this is all fairly arbitrary. It turns out the number of diseased vessels doesn't matter that much, so just do the best you can. Did all that make sense? I went through it pretty quickly. Okay. And this is just kind of a diagram trying to explain the variations. And then okay, this actually violates one of my principles, but this is an explicit STS clarification, I believe. So this is the percent. I don't remember what the purpose. I'm trying to remember. You're seeing me struggling to remember what the heck this is for, because this is just globally asking, did you even know what the stenoses were? I'm not sure why they're asking that. Maybe it's just word to say, did you have a number? Did you have an adjective? But the clarification that's interesting is, if multiple sources are available, select the surgeon's documented degree of stenosis. What do people do? Do people follow that? So, yeah.
So that, I think that's probably that little bullet at the bottom, it should be from that slide.
Anyway, this isn't all that important anyway, because the severity, we just need to know the number of vessels greater than 50%. And in general, I'm going to say go with the official report. And the reason I'm saying that, because I don't like to disagree with the STS, is when I ask that question, it sounds like that's what most of you do anyway. And it's so much easier to be looking for a typed, cath report than it is to be digging around for the surgeon having changed the number. Yes?
So this has follow-up. This actually is, the title of this data element should have the word known on it, present native artery stenosis known, and then it goes into these follow-up
Okay, so this is a parent variable. Okay, so okay, it's a parent variable, and really this is the variable that we pay attention to, which is the left main primarily. And there, they just we want to get the percentage of the left main. And there was a question.
I don't know if it's right, but I use multiple when I have both the surgeon and the cardiologist reports, and I use them all. I mean, use the highest value of them all.
So you use the tightest of them all.
The highest value of them all, but I don't know if that's what...
Well, for everything else except this one where they explicitly contradicted me, I would say look at the official report. What do other people do? Do they look, because what they're saying is the STS, which is the Society for Thoracic Surgeons, is saying listen to the surgeon. What do other people do? Cath report. I think the advantage of the cath report is it's typed and so much easier, and so and that's what we've done up until now. So I'm gonna and if I'm not getting the sense that a lot of people are doing it this way, it's both, to my mind, more reliable and easier. The question is, how do we audit it? Because that's really the point.
You know, and there's stents that, you know, I see my cardiologists write a lot. I have taken a careful look of, you know, to relook these.
Yeah.
My interpretation is this, but then maybe a stent's missing, a percentage is missing out of the cath lab report. So, you know, I think that there's value in looking at both of them.
Well, I think if somebody comments on a stenosis that's left out of the cath report, you could use the only, you know, then you only have one source. But I'm gonna stick with my guns on this one and say, if the cath report says 60% left main and the surgeon says 90% left main, we're going to audit that as 60, just because, you know.
Cath?
Say again? From the cath report. Yeah. Mainly, and they left, their qualification applies to this variable. I don't even understand what it means, but basically, I think it's problematic to be going, and it's much harder, seems less reliable and much harder to me, so, plus it actually contradicts what we say about everything else. So, and looking around the room, at least the people who are here, it sounds like they're not doing that. So I'm going to stick by my guns, which represents a tiny change from what the STS seems to say. And this is just indicate the highest percentage stenosis in this vessel at the time of the disease. And I guess that's if they say they're sequential lesions. They want you to comment on the tightest of the lesions. It's actually the left main, usually that's what we do. It is possible to have two lesions in the left main, but it's a short vessel, so we'll usually just comment on one. And this is just to say, did you know what the ejection fraction was? And basically, you know, after the induction of anesthesia, which is usually when the TEE is done, that can change the ejection fraction, so don't do that.
Now, here's where there is a lot of difference I've seen is you'll have the cardiologist just in his consultation say what the EF is.
Yeah.
And then the surgical, if it's an elective case, the surgeon will do a consultation. Those two will be different.
Yes.
So I sometimes just average them. I mean, so what do you recommend for that?
Actually, and as a cardiologist, you can try to guess what I'm going to answer. But what I would actually say is, if you're talking about two consult notes, I don't know. What I would say is we want the official echo report, if at all possible. Now,
and if you don't have that?
Yeah, so what if you don't have the official echo report or cath report? You know it was done. You're quite confident it was done. So you know that it was measured, and you have two doctors who have looked at the study, and while it's not the official report, they told you what the ejection fraction is. You've averaged them? Yeah, that's a perfectly, what I've said in the past is you can take the lower one. But if we find the cath report, we're going to audit that, and if that's different, we're going to say you didn't code it correctly. So that's, you know, because that's what, and what would I recommend? I'd recommend saying, could you please get the official echo report?
Well, we've tried that, and this is when it's not present in the cath report. It's usually from the echo in their office or something that we don't have. So that's why I have to go to the consult.
But they both looked at it?
Well, the surgeon mentions it.
Okay.
So whether
And,
it's
okay,
that.
in that case, okay, it's from the cardiologist's office?
Correct.
Oh.
That's my.
And again, I'm a cardiologist, but then I'm actually going to say go with the cardiologist. Why am I going to say that? Because in order to bill for that procedure in that cardiologist's office, that same cardiologist will have done an official report.
Okay.
And that same cardiologist so that EF is, unless they disagree with themselves.
That makes sense.
Yeah, okay. Yes.
Just an FYI, this is going to contradict what the SDS is instructing us. The reason for using surgeon's input is because it affects their decision-making.
Yeah, no,
I got a statement from the STS. I asked them a specific question, and the STS answered me and said, use the most recent, because you got the LexiScan results, you've got all these echoes, you got the surgeons, and their official response to me was, use the most recent lowest value.
On the EF.
on the EF. So I don't know whether we have it in this version of the, I don't know whether we have it in this version of our clarification, but I used to tell people which tests I consider the most reliable and how you should use them. But I actually agree with part of that, which is I would say, well, if they're all done very close together, I'd use the lowest one between those different tests. If they're all done over, a matter of a couple of weeks, I'd use the most recent one, okay? So in terms of which tests I use. Now, it's a fair statement that the surgeon their decision-making is influenced by what they think the ejection fraction is. It's also a fair statement that surgeons don't get to operate on the patient unless the cardiologist refers them. Right? The fact is we actually control the patients up front, why angioplasty is taken off, one of true. So our interpretation of the ejection fraction as the referring cardiologist also influences decision-making, and I actually think is frankly the number I'm still going to audit because it's in the official, and if there's a problem with this, then you should talk to your folks in your hospital and say, you know what, I have to go with the cardiologist number. So if you don't agree with that, then you guys should get together because that's, the surgeons are not trained to, my surgeon will come to me and say, and show me an echo and say, what do you think the ejection fraction is? Why? Because I'm the expert. I'm the one who knows how to read the study, so that's why I'm going to audit that. We're going to audit that way. Now, the SDS, which is the Surgery Association, makes this really, really difficult and confuses the heck out of you guys so that we just decide that in order to be on a level playing field, we need to change this. We might, but at this point, I think the better approach is what we've said, and if they keep issuing this thing saying the surgeon overrules the official report, maybe we'll change our mind, but for now, I'm going to say official report trumps all else. Most recent study is the one you should use. And question?
Just got a request to please repeat the attendees' questions and comments because the webinar people cannot hear them.
And thank you for reminding me of that. And you were going to say, oh?
This is a question just for me. How much do these numbers usually differ by? So we put this in our risk model. This is entered in our risk model as a continuous variable, and just wondering.
Yeah. So I think the point is that all you can do is the best you can do. In terms of capturing risk, we may ding you on the audit and change the number, but if you put 30 and we said it was 40, that's going to make a really insignificant difference to your risk. And to repeat the question that was asked here in the audience, he has that, I have a mic on.
Oh.
He asked, I was told by the FCS that I should use the most recent study if you have multiple studies other than an interop TEE. And I agree with that. I'd use the most recent study assuming you have reason to believe it was not inaccurate. But once I've decided which study I'm going to use, and if I had multiple studies done really close together, like the same day or, I might say if the cath was done one day and the echo was done later the same day or just before or after the cath, maybe the next morning, then I would take the lowest one. I agree with that. But for any of those studies, I want to use the official report if it's available. And we were asked, I didn't repeat the other question, the scenario was said that the echo was done in an outpatient cardiology office which means that cardiologist, in order to bill for that echo and get credit within his group for the RVU, he or she is going to do the official report. That same cardiologist writes a note in the chart saying the ejection fraction was 40%. The surgeon comes in and says, I think that ejection fraction is 30%. I'm going to say, use the cardiologist's written note because that's very likely to correspond to the official report that isn't in the chart, but is sitting in that cardiologist's office.
And we have asked them to try to bring that record over so we can scan it.
And the comment is, we've asked the cardiologist, please put that in the chart so I don't have to wonder, and that's a very good conversation to have. So, and these things in the end are not crucially important, but I mean, they're not crucially important to the risk, but they're crucially important to you guys to know how to abstract. I get that. And just do the best you can. But in terms of whether we take the 30 or the 40, that's not really crucial. I'm just trying to do what seems the best to me. And I think, with these STS clarifications, by the way, they sometimes have, they have multiple people who issue these clarifications. They sometimes give different answers, which is why I don't always respond to every single one of them by agreeing, because if they because otherwise I'd be blowing in the wind a little more than I already am.
Thank you.
More questions? No. Ejection fraction, we also translate, we say, some of the software doesn't allow you to put 32.5, so if they give you a range, you can use the higher number, 33 or 30 to 35. We translate words into numbers in our training manual, and so that's that. Now I'm going to move on to PA pressure. And it's the highest PA pressure prior to induction of anesthesia. The problem with this one, frankly, is you can potentially have a gazillion PA pressures with the right heart cath fed in there. It turns out the minority of patients these days have right heart caths prior to the induction of anesthesia, so this data is not available. And the only thing and I got to remember what we said, which is this down here. PA systolic pressure is not acceptable. It is acceptable to code the RV systolic pressure. There you go. The one exception to that would be, and this will almost never be the case, is that they have significant pulmonic valve stenosis, then the PA pressure and the RV systolic pressure are not the same. That's never going to happen. So I won't say never, but it's going to be rare. So if you make that mistake, I don't care. It's going to affect so few patients. Mitral insufficiency. This is one that tends to be undercoded. It tends to be left out. It actually is a risk factor, so go looking for it. And these are very confusingly, this is how they do it, 0 through 4. Well, actually, it's not so confusing. I take it back. The 1 plus, 2 plus, 3 plus, 4 plus, that's actually the same as these numbers, as a matter of fact. And the thing that's confusing to me is that 2 plus out of 4 is mild. That's confusing to me. I don't use this system because I use mild, moderate, or severe, but in any event, 1 plus is trivial, and you have to have a 3 plus out of 4 to be moderate, and then this just means not documented, so I guess that's when they say mitral regurgitation, they don't tell you how severe it was, which we do sometimes. And then it's going to be, don't use TEEs, they tell you what causes it.
Sure. So in the absence of echo, are we allowed to use the TEE result? The anesthesiologist TEE.
Yeah, I'm actually remembering what they've said, because this is slightly different than almost anything else. In that, typically mitral regurgitation is less after the induction of anesthesia. And I don't know that we've clarified this explicitly for MR. Anybody remember? We don't like you to use ejection fraction from this, but
I think as a last result, I think the STS said you could use it.
Yeah, and I believe that's more or less what we've said. So I would say we're going to abstract looking for any other source, but if this is the only thing that's available, I believe that is what the STS does say. So yeah.
Also, I think in the new version of STS that they've actually broken out mitral insufficiency and mitral regurgitation. So how are you collecting those data?
I'm going to bet they didn't do that because those, to my knowledge, are exactly the same thing. There is no difference between them. I cannot think of which one's the difference. And a question from webinar land?
The latest STS conference specifically said that the 0 to 4 scale is not synonymous with the word. They said we must ask the MD rather than assign a number based on the words for mitral insufficiency.
Oh my God. I don't even understand that. Does anybody understand that? So, go back. You mean the 1 plus 2 plus 3 plus 4 plus they say is not equal to the word?
I think that's
what they mean? So if the physician puts, okay, well, I do kind of understand that. In that, one of the concerns I've had is, let's say somebody puts 2 plus mitral regurgitation. Could they mean 2 plus out of 3, in which case that's moderate? Or could they mean 2 plus out of 4, in which case that is mild? And so that's maybe what the STS means. So it would be useful for you guys to know that. When I tell the usual, and maybe correct me if I'm wrong, when I say 2 plus mitral regurgitation, I'm assuming the 4 plus scale. What are you assuming?
Yeah.
So we're going to audit that as mild. So if they say 2 plus mitral regurgitation, we're going to audit that as mild. If you know that isn't how your cardiologists work, they haven't invented the 3 plus scale, which sort of intuitively makes sense to me. 1 is mild, 2 is moderate, 3 is severe. That kind of intuitively makes sense to me. I always worry that's what people are doing, but in fact that's not the accepted thing. So I'm going to say ask them to write moderate instead of 2 plus because it's going to confuse the auditors, and we're going to audit it as mild. Question?
So a follow-up on that question makes no sense to me either, but they were insistent. STS says that there is no standard for the 1 plus, 2 plus, etc. I believe we all use the scale as recommended today, but STS was adamant.
Well, we're going to audit the way, so this is what I'm going to say. We're going to audit it the way we audit it, and if you want to take the trouble to ask, that's fine. I think what the STS is saying, and I'm saying the same thing, is you should know for sure that 2 plus means mild and not moderate. If it does mean moderate, then you're going to need to ask them to write something other than 2 plus because we're going to assume it means mild. So if you want to just say that's mild, it's okay by us. Frankly, I think it's okay by the STS. I think what they're saying is they're saying it might not mean mild, it might mean moderate, you should ask.
Our hospital puts a policy together, and we have the cardiologists and the surgeons approve the terms that we use for numeric values on a lot of things. So I think that's a good recommendation for us to consider, having the policy established, and then when you come to audit or STS comes to audit, we have our policy.
And so the comment was that basically you guys talk about it and decide what you're going to do. And 2 plus, if they vote 2 plus?
2 plus is mild.
And 2 plus is mild. So I think what I'm hearing is 2 plus, the standard is that that's mild. If you're wondering whether that's really true, the STS is actually recommending that you confirm that because in their opinion, some people don't mean mild, they might mean moderate, and that would be to your benefit to know, yes.
I'll try. You can just repeat this. The training manual is correct, but on the slide, we didn't update the language with their recent. So it does say, indicate whether there is evidence of mitral valve insufficiency / regurgitation. So it includes them both.
Yes, they are synonymous. They're 2 words for the same
I
thing.
have it on there.
And to correct it, they added in stenosis. So they had insufficiency before, but they now are broken that down into insufficiency and then also stenosis.
Yes,
category.
Right, and for, we haven't been collecting severity of mitral stenosis as a risk factor to date.
So they just added it.
Yes. Well, I think they've had mitral stenosis for a while, to be honest, because that's a reason, because their system is, okay.
They only had it.
And it's an important thing to know if you're operating on mitral valves to know whether it was stenotic. That's definitely true. So, all right. And I'm the only one who thought this was confusing. So if they say this is your first re-op, that's your second surgery, I find this bit, first is your second surgery, second is your third surgery. Personally, that seemed a little confusing to me. And if you want to know something for which there is no standard, what do people mean when they say they're a first-generation American? Turns out they don't mean the same thing. Some people mean I'm the first person in my family who was born in the United States. Other people mean I'm the person who immigrated. Seems like this is kind of the same thing. But in any event, I've never been asked a question about this. People seem to figure this out, which is, anyway, these numbers is what surgery it is. So, and then we're talking about what is a cardiovascular surgery. That's defined down here. And the sort of rule of thumb is if they had to get into the pericardium, the concept here is if there's scar tissue in the pericardium, then when they go back in there, it's going to be difficult to operate. So if they were operating on the descending thoracic aorta, they're not going to get into the pericardium necessarily, and often that's done with stents these days. But if they did a proximal aortic root replacement, that's actually essentially a cardiovascular surgery, so we would count that. I think that's more or less what this gets at, because we're just wanting to know, the idea here is when the surgeon goes back in there, are they dealing with nasty bleeding scar tissue, or are they, as they say, pristine tissue planes? So, status. What time is it? Are we done? Can I leave? Status. Actually, this is an important variable, and it's not as bad as it seems, but basically I did comment earlier that you can be a high-risk elective patient and a low-risk emergent patient. The rule of thumb here is that elective patients mean they either waited at home for the surgery or they could have waited at home. They may have waited in the hospital, but they could have waited at home. Urgent means they could wait, but they had to wait in the hospital. They didn't necessarily have the surgery the same day that the problem was diagnosed, but they were not deemed to be able to go home, not because of convenience or because they have to be admitted after the cath, but because there was some clinical syndrome that suggested there was some urgency. Emergent, basically the rule of thumb is they have to be operated on today. You can't wait till tomorrow. If it's Sunday, the surgeon comes in and operates on them today. And that's for some clinical reason. And then emergent salvage, which is an exclusion, we don't report those cases, mean they're either undergoing, they're getting CPR within an hour of the procedure, or they're on ECMO when they go into the procedure. And the STS over the years has offered a whole series of examples for what would be included in these different categories. So, for instance, if you have one reason, the scenario I gave where the 55-year-old cardiologist was an emergent case because he had ongoing chest pain with his non-STEMI, that would be emergent because you have, ongoing chest pain. There's a little bit of a gray zone. If they stick a balloon pump in that 55-year-old cardiologist, the chest pain goes away and they wait 48 hours, kind of becomes urgent. So it means how well you treat your symptoms might change your class a little bit. So I'd say that we see errors between all of these. So a balloon pump by itself doesn't necessarily mean you're emergent. Some people sort of seem to at one point feel that it did. And I suppose it doesn't necessarily even mean you aren't elective, although most of them are going to be not elective. And then the fact that you waited in the hospital doesn't necessarily mean you weren't elective if you were just admitted. And that brings us to anatomy. So you can be, and there is this phrase that says anatomy is the reason why you, instead of being elective, you might be urgent. What is that anatomy? To my knowledge, the STS has never actually issued a statement. So when this came up initially, I thought, well, God, I almost never admit people after an elective cath. But basically what we said was left main greater than or equal to 80% was our definition of anatomy. You can quibble with that. And in fact, plenty of people get admitted for anatomic reasons, by nervous cardiologists, but in terms of what we thought was actually urgent, that's what we said. You guys all have been coding this, so is there any questions about the status? And again, status is just a marker of urgency. It is not a marker of global risk. I've seen patients who are really high risk, and people want to bump up their status because they're really high risk, but it's the other risk factors. And urgent, emergent reason. What I hate about this is that they don't separate these out. I know, but
Well, it's the way it works, because you've only selected urgent or emergency.
we know what you meant, right? That's good news. But it seems to me what they don't do in this slide is tell you which ones qualify for which. But that said, some of these could potentially qualify for either category depending on the clinical scenario. So I guess it's not an inefficient way to do this. So you get to tell us so that we can, clarify why they were urgent or emergent, and that's helpful for us to double check stuff. And then, gosh, these patients are generally going to be getting isolated valves, I'm going to think, but anyway. All right, cardiopulmonary bypass utilization. This is not a risk factor, to be honest. I don't think we risk adjust for this. This is more of a research thing because we're just looking at trying to capture off pump and get an idea, because this is a decision they make as how you're going to do the surgery. So we don't risk adjust for this. This is an idea. This is the choice the surgeon makes and how they're going to do the surgery. We want to measure the quality of their decision making. This was a research tool. It's not a risk factor, and it just means are they on pump, and then we talk about conversion to so forth. Yes?
If this takes too long, I understand you don't have to address it. But in the recent data, I'm hearing from some of my cardiologists that, there used to be a benefit to being off the pump. And we do have some surgeons that try to do a lot off pump.
Right.
Some disagreement, if you will. Where does the literature stand on that right now? If it's too long, I understand.
So this is more of a question of interest. I'd say your comment about what the cardiologist said is correct. There's not a clear proven benefit to being off pump. It turns out I come from a hospital where we have a lot of surgeries done off pump. They're very good at it. Their outcomes are very good. I suspect their outcomes might be very good if they did them on pump, because they're just good at doing them off pump. And I sort of think of it as you don't want a surgeon who doesn't like to operate off pump, operating off pump. The surgeon needs to be comfortable, because there is not a good proven benefit to doing it.
Thank you.
Yep. It does not reduce stroke in the way that we hoped it would, or that pump head, as we call it, the sort of mild encephalopathy that comes from. Yes.
So sometimes we do look at this data, we don't use it, but we get calls for people that want to know places that do the surgery off pump. It has come up at our surgeon appeal meetings, or at least probably 4 of the appeals where they've tried to argue that a case was
because they didn't
more risky because they did it off pump. So.
Well, that's the decision they make, right?
So that's, right. So again, we don't. It's not in our public reports, but for the reason.
Yeah.
And the literature has been discussed at our CAP meetings, but not anything that's come out recently in the last 2 years.
Yep. But we're definitely not going to risk adjust for it. Now, we were curious. Why did we collect this? We were curious how many cases are being done off pump, and certainly if we've seen, my God, the mortality is much lower, the stroke rate is much lower in our data for the people done off pump, we would have published a paper and said, hey, you guys might want to do it off pump, because we have this huge data set. We didn't want to miss that. Turns out that hasn't been borne out in randomized trials, but, and again, I would, in terms of what patients really want, some patients, who believe in this might want an off-pump surgery. What I think they want more than that, what do they want more than that? Quote, minimally invasive. They want the alternative incision. That's what they want. So, and TAVR. So, okay. And the rest of this seems pretty straightforward to me. Plan the law. Okay, mammary artery used. again, we're not going to, we actually present this as a process measure of quality. In other words, it's something you do, but we think that good quality surgeons will do a very high rate of mammary. In fact, as we started to publicly report it, the rate went up. And so, because remember I said that mortality is not the only measure of quality of surgery. We want to know how long the patient lives and whether their angina is well relieved. And we know that's associated with mammary use. People live longer and they do better long term, so that's why we measured it. And then, but we recognize there are legitimate reasons that people might not use mammaries, and we wanted to give people credit for that. That's what this is about. And this is just where you tell us whether a valve surgery was done. This is where you tell us whether it include the aortic valve. Now, this is kind of the opposite of what we just talked about. This is where the valve is a complication of the bypass surgery, I guess.
Well, it's not a complication.
Well,
It was done in the same surgery. It could have been planned.
No, they're saying,
Oh, down there.
yeah, so this would just be your bypass plus valve surgery. That's just the ones you'd report. What I'm wondering about is unplanned due to surgical complication. I'm going to have to come back to that one because I'm going to have to think about it. This one is going to be unsuspected anatomy. You know what? Okay, so this one is going to, now, if they do the root, which this implies some of these are going to include a root, it's going to be excluded, it's not going to be publicly reported. But what if they go in there, and this does happen, going to do a bypass surgery, knew they had aortic stenosis, we thought it was moderate, we get in there and we go, whoa, that valve looks awful, just looks awful. Then they call me at 7 o'clock in the morning, I rush in there, sometimes they FaceTime me the images, and we say, what do you think, should we replace this valve? If we replace that valve, that would be an aortic valve plus bypass surgery. I'd put it into that category because that's not something that was caused by the surgery. That's them making a decision at the time, and I think that's legitimately not the same risk. We want to we're going to publicly report that case, but we want to do the appropriate risk adjustment, and I'd say the appropriate risk adjustment would be to include that. I wouldn't call that an isolated cabbage just because we decided to do the aortic valve after we entered the OR. Does that make sense? Now, this is number 4, unplanned due to surgical complication, and so it's unplanned due to surgical complication. I'm having a struggle with this one. If you have reason to believe that the aortic valve was normal before they entered the OR and didn't need to be replaced until the surgeon did something, like in probing the left main coronary artery, ripped the aortic valve, I've never heard of this, and then needed to replace it, that would be a complication of an isolated cabbage and probably should be lumped into that category, because we kind of want to penalize the surgeon for messing up a perfectly good aortic valve. I can't believe that's going to happen very often. Did that make it all sense? Okay. Alrighty, and but otherwise, most of these are just going to be your aortic valve plus bypass surgeries that this is just a parent variable for that, and then you're going to ask, what did you do to it? What did you do to the mitral valve? And I guess this is going to be the same thing because, and I cannot come up with a bypass complication that would lead you to need to do a mitral valve, to be honest. I would make the distinction of, anyway, if you really did have this, it would be an isolated bypass surgery, but I just can't think of a complication. Again, I guess you went in there and tore the mitral valve, but boy, those are going to be, I've never seen that. So, mitral valve procedure, what did you do? Tricuspid valve, we don't publicly report tricuspid valves, so I don't quite know why we're collecting this other than maybe for completeness sake. Same thing with pulmonic valve, reoperation for bleed. Okay, now we do get some questions on this one, and I'd say the question we get, okay, well, so first of all, reoperation requires opening the chest, does not chest tissue, chest bleeding. prior to patient, blah, 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 patient must be, okay. I'm just remembering all the things we said. So, occasionally these people have ICUs that are equipped to be ORs, and they don't actually physically move the patient, they just reopen the chest in the ICU and do what other people would have done in the OR. And then, if we have a camera in our OR, and we can watch the surgeons, and there's always this I have a running joke with us. You guys aren't really working very hard, because after they finish the case and they close, they reverse the anticoagulation, they just sit there, right? They're basically waiting to see if the patient's tamping on. They're waiting to see if they've stopped the bleeding well enough, because they don't want to leave the OR. If they figure out that the patient's bleeding and fix it before they leave the OR for the first time, that's not a re-op. That's what that means. And then the only other thing to say is, if you have to go back, sometimes the chest tube is putting out a lot of blood, and they go back in there and they re-op, and then when they get there, they sort of don't find blood. We've counted that as a complication where they've had to re-operate for excessive chest tube. Usually the patient's a little hypotensive, and they think, oh, there's tamponade, and they go back in there and there's excessive chest tube output, but they get there and they don't really find anything. Trying to think of the other things where we've clarified this. Oh, that's this point here. That requires surgical reintervention to investigate. That would be to investigate, right, even if you don't find it, or correct. So the STS actually says the same thing, which is probably why we answered that, because we read that sentence. Anyway, so that's what these re-ops are about. Now, that then brings us to reintervention for myocardial ischemia, and I believe now they actually, right. So the reintervention now includes percutaneous reintervention. I think the STS actually explicitly says that, even though this doesn't say that. In other words, in an earlier iteration, if a graft closed down and you had to do something to open it up, it was sort of a little ambiguous about whether if you went in there and angioplasty that counted. But because they used to call it reoperation. Now they call it reintervention. They don't call it reoperation, because we almost never do that. I mean, if the graft closes down, occasionally we stent them, but we very rarely take somebody back to the OR. So that's what this would mean, any kind of intervention for a graft closure that happens after they left the operating room, including percutaneous. And I guess we're going to ask whether it's a graft or a native vessel. And then, and interestingly, and then deep sternal wound infection is rarely diagnosed during the index hospitalization, and we fully know that we only capture a few of these because normally this data is not available because the patient is long gone by the time this happens. This gets us into stroke. When I read these charts after the fact, I'm quite surprised what people are willing to say wasn't a stroke, because it's like, but, there are times when people disagree in the chart, and there's some permanent neurologic deficit, or there's, I'd say the ones that I've had the most trouble with when I've read them after the fact are where the patient has an acute symptom, they do a scan, they see a stroke, and if it's a CT scan, we can't necessarily tell whether it's old or new, and then the symptoms get better, and then somebody writes in the chart, this was an old stroke. And I'm like, really? This looks like it was an acute stroke. Now, with an MRI, they can actually they can tell you, the current generation of MRIs can tell you how recent the stroke was. But anyway, we sometimes end up auditing those where we're like, it looks like it was an acute stroke, even though somebody was willing to say, oh, I think it wasn't. But in any event, these are meant to be, strokes where the symptoms lasted more than 24 hours, so we're not counting TIAs, and although I think we count that. It can be of any type of stroke. Yeah, so that's basically it. And undetermined type, I think from our point of view, stroke is a stroke. This is an outcome that we do care about, we do report, but it's, I don't know that we care about the type of stroke. It is, and I forget what people have used undetermined for. I mean, generally I would say it's ischemic unless you see hemorrhage on the CT scan. So the undetermined ones, I think that's come up when they didn't get a head scan because they died. Yeah, that has happened, yes.
If symptoms resolve within 24 hours, do we mark no, even if the scan neurologist says there is a stroke?
Yeah, that's a good question, and
I would say yes, wouldn't you?
yeah, I think if it shows up on the CT scan, then the reason I say that is that the actual definition of it, the modern definition of a TIA, I don't know if anybody knows this, is way less than 24 hours. It's actually, a TIA is, the definition is that really the symptoms go away within less than an hour. Otherwise, if you image well enough, you will see a stroke. If you don't see a stroke on a high-quality MRI for symptoms that last more than an hour, then it actually might not have been a stroke, because there are other things that can cause neurologic symptoms. Because most quote TIAs that last more than an hour actually show up on a scan as a stroke. So I would say if you have somebody who's clinically saying the patient had a stroke, and it showed up on a scan, and when you read the chart, it's not clear the symptoms persisted after 24 hours, I'd still call that a stroke. I haven't always said this, to be honest, but why am I saying that? Because part of the problem with strokes that I was always concerned about is whether you see them or not depends how carefully you examine the patient. If it shows up on the scan, I'd say very often if you did a careful exam, it would have been evident. And clinically, there's been some injury to the brain if it shows up on the scan. So I think the intent of this is to capture, an outcome we care about. So that's what I would say. Dr. Matchison, do you have yeah. And it sounds like that's how most people would code it, based on the nodding of head. If the symptoms, you weren't sure the symptoms lasted more than 24 hours, people are saying, oh, the symptoms are much better, or they're gone the next day, and then they see a stroke on the scan, and the neurologist says the patient suffered a post-op stroke. If it goes into the past medical history, it's now part of it. What would you guys say? Stroke. Okay, it sounds like that's how people are coding it, and to be honest, I think that's what we're trying to get at, and I have a question in webinar land.
The same person has a follow-up comment. They often don't mention whether the stroke is old or new based on scanning.
So on a CT scan, you can't always tell whether it's old or new. That is true, and that's where I've been a little surprised when somebody did a scan for symptoms which were new. They then see a stroke that they can't tell whether it's new or old on the CT scan that's in the right part of the brain to correspond to the symptoms. I'd say you have to assume that was a stroke that happened then. Now, this is where you get to be really nuanced, and thank God you all are ICU nurses and well-trained people. Otherwise, what if it's on the opposite side of the brain from the symptoms? That's probably an old stroke. So if somebody had right-sided weakness and they had a lacune on the right side or something, that's probably unrelated. It's on the wrong side of the brain and needed to be on the opposite side of the brain. So you can say that was an old stroke that had nothing to do with the surgery. That's pretty nuanced, but that's you guys are good enough to do that, and that's really, frankly, what it takes to be. But it helps when you have somebody, a clinician, writing in the chart, I think this patient suffered a post-operative stroke. That's helpful, but I know from a fact, having audited these, it's not always there. Yes?
STS definition says stroke if it doesn't resolve within 24 hours. If symptoms don't resolve within 24 hours. So if they don't resolve, it's not a stroke.
Well, they're implying, what they meant to say is, they were meaning to do a distinction between a TIA and a stroke. But we were asked the question here, what if somebody said they had a stroke, but it looks like the symptoms improved, maybe even got a lot better, maybe even went away within 24 hours, but the scan shows a stroke, the neurologist says they suffered an acute stroke. What should we code? Most people are saying they would code a stroke, and I'm agreeing with that because the more careful a clinical exam you did, in that scenario, you probably would pick up some residual symptoms, just that the residual symptoms are mild, because and I'm saying that because that's actually a complication we care about, as well as the way people are coding it anyway, which makes sense to me. Now, the STS is not saying that it isn't a stroke if it persists for more than 24 hours. Is what I think the questioner said. Is that what the questioner said? That if it lasts for more than 24 hours, it's not a stroke? Or if it doesn't resolve, it's not a stroke?
If symptoms don't resolve within 24 hours,
It is not a
be
stroke.
rewritten. STS definition says stroke if symptoms don't resolve within 24 hours. So if they do resolve, it's not a stroke.
Yeah, so that's the implication of the sentence, and so the answer is yes, but we're saying if let's say the head scan is negative, nobody writes in the chart that they suffered a stroke, and their symptoms, they have stroke-like symptoms that resolve within 24 hours, you can say they don't have a stroke. That's correct. That would be a TIA. Now, the modern understanding of this is really to have a scan negative neurologic event with no brain damage. The symptoms do not last 23 hours. They last like 23 minutes. If you have symptoms that last much over an hour and do a careful enough scan, they have usually actually suffered a stroke. But we're saying negative scan, no neurologist says they had a stroke, resolved within 24 hours, which is the old definition of the TIA, you can say no stroke.
And then a follow-up comment from the same person, neuro-MDs overcall strokes from scan.
Gosh, that's actually not my experience, but it is true that there are lots of little things that are commented upon on MRIs, small vessel, this or that, high, signal, small vessel things, stuff like that. I have personally had a head MRI for some symptoms I had, and I had little things on my scan, little high signal things, and my neurologist said, no, don't worry about it. Good looking brain is this comment. So basically, there are lots of little things that could be sort of ischemic changes, but current generation of MRIs are actually pretty good at telling you when it's a stroke and even telling you when it occurred. Really, really, really small strokes are supposed to be overcalled, but that's not so much my experience, but you can only rely on the neuroradiologist who read the scan. And here again, I'd rely on the official report if that's what, but you should mostly be, at this point, if the neurologist comes in and says, this patient had a stroke, that's a clinical diagnosis by an expert, you're mostly going to rely on that. You're not going to try to interpret the scan separately yourself. But if for some reason you were trying to make a decision in an ambiguous situation based on the read of the scan, because nobody wrote a clarifying note, then you would rely on the official scan report if you were going to use that information, but mostly you're not going to do that.
And then my last comment from this person, and then we'll move on. Many times, not a clinical stroke, but are called based on imaging only. Can't tell if old or new. Why penalize surgeon?
So that I agree with. I agree if there are no symptoms, but I will tell you that we don't scan people's heads post-op in the absence of symptoms usually, but I will say there is an exception to that. Patient is like groggy after the surgery. They're basically encephalopathic. They're basically, so this is maybe a scenario where you don't want to overcall it. The patient's encephalopathic, no focal symptoms. We do a CT scan. Basically, the CT scan actually looks okay, because what are we looking for? We're looking for a bleed. That's what we're looking for. Patient wakes up. They seem to be fine. It's not that their arm was weak or something like that. It was that they just were sort of, unresponsive. They wake up. Their CT scan shows a stroke that we don't know whether it's new or old. I would not call that a stroke, because the clinical syndrome really is consistent with the lesion that we see on the brain, right? Because it takes a mass, for somebody not to wake up, that's a very big stroke, right? You have to affect both sides of the brain, et cetera, so that's not consistent with sort of a possible old stroke on a CT scan that might be recent. Could they have had a stroke? Yes. In fact, if you do really, really careful MRIs, micro lesions occur post-cardiopulmonary bypass in a very large number of patients who we never say have a stroke. That's one of the things. I was actually kind of very worried about the whole stroke as a complication, although it is one we care about, because the more carefully you look, the more you see, and that is the problem. And so I would say no. If you have no symptoms at all ever, even that resolve, or you never have any symptoms, and for some reason you do a scan, And the only scenario I can think of is when it turns out what they had was encephalopathy, or they just didn't wake up from the anesthesia because the anesthetic hung around, but then they wake up. Those aren't stroke symptoms, that's encephalopathy. And you were looking for a bleed, you didn't find it, you found a stroke that may or may not be old. I'd call that no stroke. I hope that helps. You can see how complicated this gets in a hurry. That's why I said you have to use clinical judgment, but it seems like I'm seeing people nod their heads, so that's because you guys are clinically very knowledgeable. And prolonged ventilation just has to do with adding up lots of painful times, because you got to add up the total cumulative vent time. I never get asked questions about this. Does anybody have problems adding up the hours of, and if it comes out to 24 hours, then you get to say they had prolonged ventilation. Renal insufficiency, there's a definition there that's actually pretty clear. I never get asked about this one either. Basically says that if a creatinine went up, and if they were on dialysis, this, unlike AFib, if you're on dialysis going into the surgery, we're not going to blame the surgeon for it afterwards, but anyway, so that's reasonable. And AFib we talked about already, that kind of inexplicably, it could have been a pre-existing problem essentially, but we're going to blame it on the surgeon. I will say, the good news about this one is, I don't care very much about AFib, and patients don't care very much about AFib. It happens to 30% of people post-bypass who never had AFib before. It's a very common, relatively unimportant event that occurs after surgery. So I don't think it's a complication we care about, hence the fact that we have a definition that I don't agree with is less important, but because I don't think we're penalizing anybody to say their AFib rate is this, that, or the other thing.